Good evening, madam. I, Shuman, on behalf of Shield Healthcare, welcoming you and all the participants in today's webinar. Prior to moving to the webinar, let us introduce the Shield Connect page. This is our Shield Connect page. It is a knowledge sharing platform of Shield, and we have many key opinion leaders in the platform who are giving the valuable knowledge to us, and we have different blogs written by different doctors and healthcare professionals. We have our key leaders. Those are key opinion leaders, as well as some special events associated with this, that is Hypertension Day or Mother's Day or Safe Motherhood Day, GDM special, Women's Day special. With each and every tab, you will find lots of articles regarding the regarding different webinars. So now let me start with the webinar, and before that, I must request all the participants to post your queries in the QA section of the dashboard. And once the webinar will be completed, then we will have a short discussion with madam regarding the topic. And today's the topic of the webinar is the art of laparoscopic myomectomy, and our guest speaker is Dr. Mala madam. So let me introduce Mala madam. With Madam has completed her undergraduate from Kilpauk Medical College in 1992 and post-graduation diploma from SRMC in 1997, diploma in endoscopic surgery from University of Kiel, Germany, and diploma in reproductive medicine from the same university, that is University of Kiel, Germany. Aesthetic gynecology training she took from South Coast Urogynecology, California. She is the managing director of Forms Hospital, Chennai, Secretary IAG Tamil Nadu chapter, and she was the executive committee member of OGSSI from 17 to 20. Madam was the first secretary of IMS Chennai chapter 2010 to 12, and she was FOGSI endoscopy trainer. Also, Madam has lots of awards to her credit. She got the Best Doctor Award from Tamil Nadu MGR University, Times Healthcare Achievers Tamil Nadu 2018 Award for Stalwart in OBG, operating faculty in various conferences, and she got Dr. Shivle Rudrasina Award for Best Paper in Gynae Endoscopy at AICOG in 2006. With this short introduction, I request Madam to take over the session and your valuable talk.
Yeah.
So thank you, Madam.
Yeah. Thank you, Mr. Suman. Okay. Can I share my presentation?
Sure, ma'am. Now you can share it.
Yeah. So to start with, my heartiest appreciation for the entire Shield team for carrying out such a wonderful academic activity during this COVID times, which is keeping all of us really busy. In fact, this is a very good opportunity for people to really upgrade their knowledge and also to learn many new things. I'm sure this entire 1.5 years, people have become more knowledgeable because of this, the pandemic. This is looking at the other side of the pandemic. Of course, we really know how hard it is and how we all are suffering with because of this particular situation. But then there is something we have to look up on the positive side also to brighten us up and keep us moving forward. Okay, so now coming to the topic today, the topic is the art of laparoscopic myomectomy. Myomectomy is a surgery which not only I enjoy performing, but it is something which I like to talk about also because I have understood this fibroid to a phenomenal extent because having doing quite a lot of laparoscopic myomectomy, I find these fibroids are very, very fascinating because each and every fibroid is so different in each and every individual. So our management also varies accordingly. So first and foremost, what we need to understand is we need to understand the fibroids before starting any kind of laparoscopic myomectomy in a particular individual. So because we need to understand fibroid both at the molecular level, the anatomical level, and also the surgical level, so that we will be able to offer the right kind of modality for that particular patient, because the requirement of each and every individual patient is very different. So mainly they either come to us with heavy bleeding and pain where AUB is a concern, wherein they just want that to be, corrected and save the uterus, or they want to achieve a pregnancy where the high fibroid is being a big hindrance for their conception. In such a scenario, we have to ensure that we not only remove the fibroids, but also make sure that the functional capacity of the uterus is well maintained, and also the anatomy of the tubo-ovary relationship is not disturbed, so that we do not compromise on the fertility potential of this particular lady in future. So having said that, the history of laparoscopic myomectomy goes long back to Kurt Sim, who first demonstrated laparoscopic myomectomy way back in 1992. And ever since, we have evolved in a very, a long manner by with the help of various technologies, and also our surgical skills have also been improvised, and we are able to do very fine laparoscopic myomectomy even for difficult cases in odd locations for multiple fibroids. Earlier, there were limitations for laparoscopic myomectomy where the cutoff was only 3 fibroids, and the size of the uterus not more than 12 to 14 weeks. But now we are able to perform the same procedure for multiple fibroids and also the real huge and giant fibroids. So with the advent of the morcellators and the refinement of our surgical skills, so one needs to understand how exactly this laparoscopic myomectomy is different in a infertility patient. Because in infertility patients, as I mentioned earlier, we not only have to maintain the anatomical correction, but we also have to ensure that the uterus is working to its optimum and also is able to go through the pregnancy without any eventuality. So with coming to the infertility, first we need to understand which are the fibroids which we need to remove. So not many a times it is better, certain fibroids are left undisturbed rather than be removed. So because we do not want any multiple scars on the uterus, so that, the integrity of the uterus is well maintained. So the most important thing that we need to remember is that the submucosal fibroids, be it the small or the big, needs to come out. So because this is definitely going to hamper the infertility potential of the lady, and we know the reasons why. And also the intramural fibroid is always a controversial one. So we are not sure which are the intramural fibroids to be removed, whether to be removed or not to be removed earlier. But now we have very clear guidelines stating that the intramural fibroids of more than 4 centimeters, it is better they are removed. In fact, there are various papers where they have said that even the fibroid, if it is above 2.8 centimeters, it is also better to be removed if they are very close to the junctional zone. Because the junctional zone is the most important factor for the fertility of the women, because all the growth factors, the neuropeptides, all those things are present at the level of the junctional zone, and the contraction of the uterus also originate from there. So any fibroid which is very close to the junctional zone needs to come out. And also, per se, the fibroid produces quite a lot of abnormalities like increased prolactin and aromatase. All these are a fertility deterrent. So as a result, these fibroids, if removed, may in fact improve the fertility of a woman when all other factors for fertility have been ruled out, including the male factors. Now, coming to the subserosal fibroids, it is generally understood that subserosal fibroids generally do not cause any issues. But one needs to understand that when we have a huge subserosal fibroid, it's going to put so much of pressure on the uterus, and it can, even if it does not hamper the fertility during pregnancy, it can cause preterm labor and even abortions, and can also compromise on the growth of the uterus, thereby resulting in intrauterine growth retardation of the fetus also. So as a result, if you get an opportunity to do a laparoscopy for some other reason, and if you see the subserous fibroid, it will be a good choice to remove these fibroids as well. Next, coming to the cervical fibroids and the broad ligament fibroids, it is always better to remove these fibroids, because again, the cervical fibroids is on the way, which would also affect the fertility and can cause quite a lot of issues in conception. So for both the broad ligament fibroids and the cervical fibroids, it is better we remove it in case of infertility. So what are the things that one needs to keep in mind is that whether it is mandatory to remove these fibroids, and we also need to understand whether these are the reason for infertility, provided we have ruled out all other factors for infertility, including the factors, and whether myomectomy would improve the pregnancy rate. It not only improve the pregnancy rate, it should not do any damage or harm to the uterus. So what are the special precautions taken during the surgery is what we need to keep in mind, because the surgery for an infertility patient is entirely different from that of the AUB patient, because here the suturing skill is very, very important, and we need to follow all the principles of fertility enhancing procedure while we are doing a myomectomy for an infertile patients. So coming to the surgical strategies in fertility is that we need to decide first which would be the best site of incision for this particular fibroid. So it can be either horizontal or vertical. It depends upon the surgeons. Some surgeons are ipsilateral surgeons where they suture standing on one side, with the ports on the same side. And there are some contralateral surgeons where they suture on the opposite port. So in such a situations, they would find the vertical incision a lot more easier. But what one needs to keep in mind is whether you're ipsilateral or a contralateral suturer, we need to place the incision in such a way that if we are going to extend the incision of the on the uterus, it should not go and hit the cornua of the uterus, so that you do not damage the ostia or cornua or the tubes. So that is one thing which we need to keep in mind based on on the incision. So earlier it was thought that if you make a horizontal incisions, the damage to the end arterioles are relatively less compared to that of the vertical incisions, where you would be cutting many of the arterioles, but that is not kind of accepted now because of the improved suturing skills. So now next will be that because this is a very bloody surgery, we need to ensure that we secure proper hemostasis. So, and also to make a procedure a little less cumbersome and also bloodless, we need to choose the right hemostatic agents for these patients. So if there are no kind of comorbidities like hypertension or cardiac issues, then we can use vasopressin for these patients at the dilution of 10 units in 100 ml of normal saline. But the most important thing is you have to be very clear that you inject it on the pseudocapsule. That is, you should not inject it on the fibroid. You have to inject it extra capsular, so that the pitocin goes into the plane of the capsule, and it will give you a good cleavage while you are enucleating the fibroid. Then another important thing is like, how are we going to enucleate it, and also the energy sources. So the energy source, when it comes to fertility, it is better not to use any kind of energy source, because more the energy source on the myometrium, it would cause necrosis of the myometrial tissues, and as a result, while healing, it will cause delay in the healing of the wound, and also may weaken the scar, and it is not a good idea when she has to go through a pregnancy. So in such a scenario, when we need to go through women has to go through a pregnancy, it is better to use cold cut scissors rather than any of the energy sources. And if you are using any energy source, it's always better to use the second generation energy sources like the ultrasonic energy sources. Now, coming to another important aspect of myomectomy is that we need to always make sure that we do the procedure intracapsular, because the importance of the pseudocapsule cannot be overemphasized in the fertility patients, because the pseudocapsule has quite a lot of growth factors and neuropeptides and various other factors which are very important for the fertility of the women. So it needs to stay with the uterus and we do not have to remove those capsules. So make sure that your myomectomy is always intracapsular. Apart from the fertility, the pseudo capsule also has a very important role, that is in case of healing of the wound. So because of the maintenance of the pseudo capsule, it has been found that the healing of the wound is much better when the capsules are left behind with the myometrium rather than when the capsules are left behind, because of the presence of the neuropeptides and the growth factors which would enhance the healing of the wound when they are present in the myometrium. Finally, we have to be you have to be an expert in case of suturing when you decide to do a myomectomy. Myomectomy is not like any other surgical procedure for you to start with your surgical skills in laparoscopy. We have to ensure that you have a sufficient degree of suturing skills before we venture into myomectomy, because ultimately everything relies on the suture, because we do not rely on the energy sources. It is the sutures which are going to maintain the hemostasis ultimately and also maintain the integrity of the uterus. So we need to ensure that we have a proper suturing skill before we venture into myomectomy procedures. Then finally, especially in case of fertility patients, it is a good idea to always put some kind of an adhesion barrier so that we keep the uterus well away from the surrounding structures like the bowel, so that you do not compromise on the future fertility by altering the tubo-anatomical relationship of these patients. So adhesion barrier is a must. So as I mentioned, understanding the fibroid is very important. So as that we are able to give her a proper kind of treatment modality, we need to understand that these fibroids, they arise from a single smooth muscle cells. That is the reason it is called the leiomyoma, because they are arising from a single smooth muscle cells. And various factors are essential for the growth of the fibroids, right from the growth factors to the steroid hormones, both the estrogens and the progesterones, the genetic factors. Now, of late, a lot of light have been thrown on the stem cells also in the development of the fibroids. So one needs to understand that earlier it was thought that it is only the estrogens which are mainly responsible for the growth of the fibroids, but we need to also understand that the progesterones also plays a very, very equally important role in the growth of the fibroids. So that is the reason when a woman with AUB comes with to us, not realizing that she has a fibroid, the first and the most important thing is that people tend to give her progesterones. So this progesterone will only enhance the growth of the fibroid. So we have to have a clear diagnosis before starting any kind of hormonal treatment in all these AUB patients. So the estrogen, they will stimulate the junctional zone and it induce uterine contractions, whereas the progesterones antagonize the effect of the estrogens and suppress the uterine contractions. But in the presence of the estrogens, the progesterone receptors will be expressed more to allow the binding of the progesterone to the progesterone receptors. So whether we need to remove the intramural fibroids or not is what is the real question, as the submucosal fibroids do have the deficiency of the HOXA10 gene. Similarly, the intramural fibroids also have been found to have an alteration in the HOXA10 and the glycogen levels also, which are very, very important for implantation. So though they are not encroaching onto the cavity, the very fact that they are present can hamper the fertility, so we need to remove them. So because HOXA is mainly responsible for implantations, which is found to be really deficient in case of submucosal fibroids, the same holds good even in case of intramural fibroids also. And at the same time, if you see, the glycogen is mainly essential for the angiogenesis and for suppressing the natural killer cells. So this also inhibits the binding of the spermatozoa to the zona pellucida. So as a result, we need to ensure that the intramural fibroids have to come out. So there are no more controversy like earlier. They said that intramural fibroids, it is better to be left behind. We don't have to remove them. So apart from the physical disruption of the junctional zone that occurs with the intramural fibroids, there are changes in the expressions of the estrogens and the progesterone and the receptors in the junctional zone, as I mentioned earlier, with increase in the expressions of the aromatase, which changes the estrogen receptor predominance, and also possible changes in the progesterone receptor expressions, which occurs in the fibroid. So this is what beautifully depicted in this picture, where you can see the paracrine factors also plays a very major role in the progesterone receptors alpha and the beta. And though the fibroid appears to be dependent on the steroids, the estrogens, receptors and the progesterone receptors, they are expressed in the tumor cells itself, thereby suggesting the paracrine mechanism. And these are the things which are enhancing the growth of the fibroids to a phenomenal extent. And also you have different types of varieties of fibroids. So now again coming to the effect of fibroids in fertility. So we all know that the uterine contractions, generally it starts from the that is from the cervix, and it moves towards that of the fundus. But when you have an intramural fibroids which is close to the junctional zone like this, the movement kind of is reversed. So as a result, they are the main source for infertility. So all the more reason why we need to remove them. So FIGO has come out a very beautiful classifications for us to understand the types of fibroids, so that we are able to approach the fibroids in the right manner. So of course we all know that 0 and type 1, it is better to remove them hysteroscopically, but we have this type 2 fibroids which could be either removed hysteroscopically or laparoscopically, but many a times it is better removed laparoscopically, because you have a very big defect here when the fibroid is huge. I will have some videos to show it to you all. And also of course when you have these other fibroids which are in the muscle and outside, it is better to remove them laparoscopically. So again, you have the type 4 fibroids also can be classified into A and B depending upon their proximity to the endometrial cavity, and you can decide how exactly we need to remove it. So here today our topic is going to be on laparoscopic myomectomy. I do not want to touch upon hysteroscopic myomectomy, because again that is going to be a very elaborate topic. So maybe we'll discuss in some other time. So here I will show you when are the which are the indications and which are the fibroids, that is the submucosal fibroids, which can be removed laparoscopically instead of hysteroscopically. Many a times we are in dilemma whether like these fibroids is to be removed at laparoscopically or hysteroscopically. So at a situation when we are in the crossroad, we can venture into removing these fibroids laparoscopically. So which are these fibroids which can be removed like that laparoscopically are the ones which, when we have multiple fibroids and also we have a huge submucosal fibroids. So why at all laparoscopy is important and not hysteroscopy in such a scenario is because of the increased risk for the myomas that are larger and more numerous, having or ones that are having deeper myometrial invasions. It takes quite a lot of time to do it hysteroscopically, because we know the complication associated with hysteroscopy when the duration of the surgery is prolonged. So as a result, to avoid the fluid overload, the uterine perforations and the possible visceral injury, and also the incomplete resection requiring multi-stage procedure and the synechiae formation, so it is better to remove them laparoscopically. And also we have limited evidence regarding the safety of labor following laparoscopic hysteroscopic larger hysteroscopic resection, because if you resect these huge ones hysteroscopically, we have a big dead space available. So as a result, what happens is that dead space remains that way, and it can weaken the scar, and there are reports of rupture following these defects which have not been sutured hysteroscopically. So there are concerns about the effect of hysteroscopic resection of large myoma over a significant proportion of endometrial surface and subsequent interference with that of the fertility. So this is a video of a plethora of submucosal fibroids. That is, this particular lady had almost 18 fibroids, of which 15 were submucosal in nature. So once I introduced the scope, the entire uterus was looking like a burial ground. So, and these fibroids were like small little tombs which were sitting there. So initially, I thought I would remove few of them hysteroscopically and then venture and remove the remaining one laparoscopically. But then I deferred because I felt that while doing this hysteroscopic resection, you may be damaging all these endometrium. That is, the basalus of the endometrium will get damaged, and as a result, we are not just removing the fibroids, we are creating another problem for her, which is going to be the uterine synecdoche, that is Asherman syndrome. So she is going to have a very bad raw area on the endometrium, and as a result she will develop adhesions, and we are again going to compromise on her fertility. So a laparoscope was introduced, and she did have some 3 intramural fibroids which were removed one after the another. So when I remove the one fibroid, then we're looking whether there are any more fibroids intramurally. So this is another basic advantage of doing laparoscopically, because well, you do hysteroscopically, you are going to remove only the submucosal fibroids. But when we are going to do it laparoscopically, we not only remove the submucosal fibroids, we also have an opportunity to look to remove all the different other kinds of fibroids, like the intramural fibroids or subserosal fibroids. And if you have some extrauterine fibroids, broad ligament fibroids, all of those fibroids can be removed laparoscopically, unlike hysteroscopy where you can remove just the fibroids. So it depends upon the indications we need to modify our treatment protocol. So one should be proficient to do both the procedures, the hysteroscopic procedure and the laparoscopic procedure, for which the bottom line is efficient suturing skills. So here, if you see, I have opened the endometrial cavity and have put my telescope inside the endometrial cavity and removing all of these submucosal fibroids one after the other with the help of the myoma screw and little bit of the energy source, that is the harmonic scalpel. So I'm utilizing. So the basic advantage here, if you see that in a hysteroscopic procedure, you have to rely totally on your, resection with energy source. So as a result, you're going to score over the basalis and damage the endometrium. But if you see here, in case of laparoscopy, we will be smaller fibroids are gently ovals. They don't have to be, no energy source have to be applied on them. But then you can just gently ovals those small little fibroids. But when you have a huge fibroids which are calcified as big as that, so you can apply the energy source onto the capsule of the fibroids without touching the basalis. If you see, I would have been applying this harmonic scalpel onto the capsule of the fibroid, and as a result, all the fibroids will make its way out. So you can see that all the fibroids have come out, and there is another huge deep-seated fibroids which is also again calcified. So which is also now being given traction and it is being brought out. See, the harmonic scalpel is applied on the capsule of the fibroids without causing any damage to the basalis. So finally, once you remove all of these fibroids, make a good count of it and then suture them and then remove them. So this is a main advantage of laparoscopic myomectomy compared to that of the hysteroscopic myomectomy. So one good indication to do the procedure laparoscopically in a case of submucosal fibroids is when you have multiple fibroids, that is a plethora of fibroids. So another good reason for us to do a laparoscopic myomectomy is when you have a huge fibroids of either type 1 or type 2 fibroids, which are more than 4 centimeters or sometimes even 5 centimeters. You can do them laparoscopically. So this is a huge submucosal fibroids, which is occupying the entire endometrial cavity. So you can see that the vision is not good because it is totally occluding the endometrial cavity. Then finally, I come up to laparoscopically and then inject pitocin. So having understood where exactly the fibroid is, making an incision on the myometriums, and the incision have to be deep enough to go right up to the endometrial cavity. So once you reach the endometrial cavity, then you can see that fibroid, see that spongy tissue is the endometrium. So this glistening white one is the fibroid. So we can apply the myoma screw on the fibroid, and like how we do an intramural myomectomy, we can gently give traction on the fibroid and score on the fibroid, that is detaching the fibroid from its capsule. As I clearly mentioned, even in case of submucosal fibroids also, it is always better to leave the capsule with the myometrium. So we don't, it belongs to the uterus. The myometrium the capsule belongs to the myometrium. So we don't have any right to remove that capsule. So leave it to the uterus, which would help the myometrium to heal better and also will help her for her future fertility. So this fibroid is now gently being brought out, and you can give gentle traction and also detach it a little bit by scoring on the fibroids by detaching it from its basal layer, so that you do not damage the endometriums. And finally, with gentle traction, you can see that the fibroid will come out. So here also, this is the base of the fibroid. So I'm giving traction and then scoring over the fibroid and detaching it from that of the endometrium. So that is the endometrium to which the fibroid is being attached. So you are gently enucleating it from, removing it from that of the endometrium. That is a small thing, which is a thing that is also being removed. So finally, like any other case of suturing of the myomectomy, I mean, this myometrium also can be sutured, but what one needs to understand is that just because you have opened the endometrial cavity, it doesn't mean that we have to close the endometrial cavity. So we can just suture the myometrium properly, making sure that there are no dead space. So completely occlude the dead space. Do not have to suture the endometrium separately. Suture the myometrium properly in layers so that you have a good healing of the myometrium. And as a result, you will be able to give a very clean scar for her, and you will not compromise on the integrity of the uterus, and you will not compromise on the healing of the myometrium as well. So here you have a very good clean scar, and as a result, her fertility would not be affected. So these are the various papers where they have shown laparoscopic myomectomy can be done in case of submucosal fibroids when better than that of a hysteroscopic myomectomy in certain scenarios. So an AAGL also supports submucosal laparoscopic myomectomy in certain cases like what I have mentioned. So now, having done with submucosal fibroids, so everybody thinks that when it comes to submucosal fibroids, it is only hysteroscopy. So I have shown you how laparoscopic myomectomy also can be done in case of a submucosal fibroids. Now, coming to our next type of fibroids, that is the intramural fibroids. So intramural fibroids, again, it has to be a fertility enhancing myomectomy. Don't even touch it if you are not very proficient with your suturing skills. So here you have to ensure that you are getting to the cavity. So this is my method of entry always. So I ensure that I enter without creating pneumoperitoneum. Mine is a direct entry with the endotip. This is the second generation method of entry where you enter the abdomen under vision, seeing all the layers. I have not created pneumoperitoneum, meaning I have not put in the Veress needle. So I'm able to see all the layers of the abdomen wall, and I'm entering it under vision. So this is a very scientific way of entering into the abdominal cavity. So once you see the peritoneum and the bowels, that is your endpoint. So the port placement plays a very major role when it comes with huge fibroids. You also have to ensure that how you place a port is very important. If you place the port too close to the fibroids, then you will not be able to do the procedure. There will be always hitting and clashing of the instruments, and also there'll be chopstick effect. So always place your palm above the fibroid. So you saw I have made a marking. So in the beginning, if you want, you can make a marking to understand, then place your palm above the marking, and the upper limit will be the fibroids. So this is the port placement, which is very important in case of fibroids. So now coming to the fertility enhancing myomectomy, as I mentioned earlier, when it comes to myomectomy for an infertile woman, of course, the principles are going to be entirely different compared to that of an AUB patient, because here, as I said, we need to ensure that the uterus is going to work to its optimum even after the surgery, and it should also have the capacity to bear the fetus and go through the pregnancy without any eventuality. So here I have injected pitocin, not used any kind of an energy source, and I'm using only scissors to enucleate this fibroid. So with gentle traction and counter traction, you can see that the fibroid is making its way out. Absolutely, there is no blood loss in spite of using not any energy source. So this is a small breach in the endometrial cavity. You can see the bulge, that is the endometrium. So this fibroid has gone very close to the endometrial cavity. So it is one of the reasons for her fertility. So we are slowly enucleating and removing it. So as we are removing the fibroids, we are just cutting it off from the myometrium, and then once this is done, we have to suture it. So as I mentioned, it is not necessary to close the endometrium, so the breach in the endometrial cavity can be ignored. The main reason why we don't have to suture the the opening of the endometrial cavity is that because they produce what is called as iatrogenic adenomyosis if you suture the endometrium. So that is the reason earlier it was thought it is better to suture the endometrium because the rupture uterus will be less if you suture the endometrium, but it has been found that it is not so. The rupture of the uterus can occur only based on the myometrial damage and how much of the myometrial damage has occurred, and how efficiently you have sutured the myometrium. So if you do not leave any dead space and if you suture the myometrium properly in layers, then that is a good option for maintaining the integrity and and ensuring that you do not cause any kind of a rupture at the time of pregnancy or delivery. So here, if you see, I have used a baseball stitch in the final suture so that the entire raw area goes inside. So you have a very clean and thin scar like this. So by this technique, what happens is the entire raw area goes inside, so there is no exposure of any raw areas, and you will not have any kind of an addition. So finally, I put this fibroid inside a bag and morcellate it inside the bag. So this is in-bag morcellation. I will talk in detail about it in the some other video. So I have some videos on that also. So this is called the myoma string. So many a times we encounter small fibroids on the uterus, and then we have to remove it. So in such a scenario, when you have huge fibroids, like how many fibroids you are removing, and then you have a track of it. But sometimes when you have the small little fibroids, you may end up missing these fibroids. As and when we are removing these fibroids, you tend to park them either in the pouch or in the paracolic cutter or in the, above the uterus. But sometimes, some in case of some kind of a difficulty or you're preoccupied with something, you tend to move the bowel. These small little fibroids can get discharged from the place where you have parked, and they will get lost inside the bowel. So in such a scenario, at the end, while you are trying to remove these fibroids out for morcellation, you will be literally hunting for these fibroids, and it will be wasting most of your time, because as it is, laparoscopic myomectomy is one of the toughest and tedious procedure, because it is not just you have to enucleate the fibroids properly, you have to ensure that you also suture them properly, and it is not just one or two fibroids, you have multiple of them to be sutured. So as a result, it becomes very tedious when at the end of the surgery you have to again sit and run for these fibroids. So to avoid that, you can string all of these fibroids into a mala and park them in a place, so that at the end you can just pick the string up, drop it inside the bag and morcellate inside the bag. This is also an advantage of in-bag morcellation, because when you string all of them and put it inside the bag and morcellate, it is much easier rather than doing an open morcellation. So this is yet another video where you can see that I'm doing an myoma string where all the fibroids are being strung into a mala, and then we are removing it. So one after the other, as I am removing, I'm also ensuring that I am stringing it and keeping them carefully, so that you don't have to worry about it, about losing the fibroids at the end of the surgery. So I will forward this. We have many other videos to be seen. So here, these are the small little ones which way you get lost. So you have just tie them up like this and then park it, and then you can sit and suture the fibroids one after the other without any kind of anxiety, and finally you put them inside the bag and remove it. So this is the myoma string, which is being done, to ensure that you do not lose the fibroids. So many a times people come report lipomatosis, where you see fibroids all over the liver, everywhere. So that is when they miss fibroids, or when they do an open morcellation, all the tissues fraying all over the abdomen, and you have fibroids developing all over the abdomen. So I have explained why we need to do intracapsular myomectomy, because of the importance of the pseudocapsule. And again, suturing also I have highlighted, why we need to suture. See, again, the most important thing what we need to understand is that many a times people think that once you remove the fibroid, if the dead space is more, we can cut the myometrium and make it small so that it becomes easy to suture. But what one needs to understand is that it is better not to, suture the, not to cut the redundant myometrium, because this fibroid myometrium is actually a hyperplasia because of the fibroid. So once you remove this fibroids and suture the myometrium, you have to give the myometrium back to the uterus. You do not have to remove it, because more the damage of the myometrium, more the scar gets weak. So leave the myometrium, to suture it, and just not even we have a very beautiful paper where they have found out whether we need to suture the myometrium in 3 layers or 5 layers, and they found that even if you suture the myometrium in 3 layers, it is much better than suturing them in 5 layers, because of more amount of foreign body reactions, because of more amount of the foreign body tissues like the sutures. So we have to suture them properly. Do not remove the redundant myometrium. Suture it in 3 layers, but ensure that there is no dead space, and suture them properly. So the importance of barb sutures, I'm sure all of us are aware. They have made our suturing skills very, suturing techniques also easy, and suturing also very easy. So because of its various advantages, they have also kind of seem to be scoring over that of other smooth sutures like the Vicryl, because they eliminate the knot, and also you're able to suture fast. You don't need an assistant to hold on to your sutures, and there is less tension on the suture line, because of the even application of the sutures on the suture, traction on the suture line. So apart from that, you can also do the box stitch when you have an intramural fibroid like this. When you have a deep intramural fibroids, as I mentioned earlier, you don't have to remove the redundant tissues. So here now I will show you how we can remove these huge fibroids and suture them intermittently with barb sutures called the box stitch. So here you have a huge fibroids. Again, the pitocin has been injected onto the myometrium, and we are inoculating the fibroids. So just one thing we have to understand is always be a little liberal in your incision. Don't think that you can make a small incision and then try to pull the fibroid out. No, making a mistake if you make a small incision and think that you're always be very generous and liberal in your incision, so that you will be able to deliver the fibroids much easier. So after that, suturing also becomes very easy. You have to take 1 or 2 bites extra, doesn't matter, but then your enucleation of the fibroids becomes simple if your incision is large. So here you can see how the fibroids literally walks its way out, because you are made a appropriate incision and a liberal incision. So at the base of the fibroids, this again has gone right up to the endometrial cavity, though the endometrial cavity is not open. So you have to at the level, see, generally all the fleeting vessels are present at the base of the fibroid. So we have to be very careful at the base, so that you are able to enucleate the fibroids properly. And then park this. This is a single fibroid, so you park it carefully. So I prefer to place them behind the uterus, or above the uterus, where exactly. So I place it posteriorly, so that it also kind of helps to antivert our uterus. So you can see that the uterus is sitting right on top of the fibroid. So you have a natural antiversion also. So then you do a thorough cleaning, and then assess how exactly you're going to suture. So this, we don't have to remove any of the redundant tissues, or even if it is bigger than the C. But one thing, see, did you see how I'm far I'm taking the bite? That is very important. When you say that you are going to occlude the dead space, that means automatically your bite is going to be well away from that of the site of the incision. So in that way, you will occlude the entire dead space. So in that way, you take it well away, and you can make what is called the box stitch. So here I've taken one bite now. Then if I will, it's something like a mattress stitch, how we do it, So you come back again in the from the same side to the opposite flap, and then again you come back, and so with your, so you have to be able to suture both your the right and the left hand. So now I'm using my left hand to come back to the lower flap. So in this way, you now tighten it through a knot. So this is something like a mattress, which we call it as a box stitch. So this, if you have a very huge fibroid, and if you're worried that you will not be able to take a proper approximation, then you can take this kind of a suture, where you can make a few intermittent stitches, and then you can over this, you can use a barb sutures in 1 or 2 layers, and finish your suturing. So you tighten it, and then the same way you have to Okay, so this is a box stitch. I'll forward it a little bit. We have few more videos. So this you have once you're done with. So I have done 2 or 3 box stitch, and finally is the baseball stitch. So this is the barb sutures. Barb sutures again. I'm doing it one more layer of barb sutures, and finally I'll be doing the baseball stitch. Baseball stitch is in out, in out, in out. So finally, if you see, you can have a very clean suture line like this without exposure of dots of the dead space, and finally you can put it inside the bag and morcellate it inside the bag. So the technique of in-bag morcellation I will show you in a different video. So this is again intermittent suturing with intermittent suturing. So we will move this. About the importance of barb suture have also explained in detail. So now coming to the cervical fibroid. Cervical fibroid again is a biggest challenge because of its position. In such a scenario, how are we going to make an incision? You can either make a vertical incision like this, or you can make a horizontal incision. But if you're going to make a horizontal incision, you have to be very careful that you do not go and damage the ureter. So our Lakshman Rekha is the uterosacral ligament. So we have these 2 uterosacral ligament on either side. We have to be very careful that if you cross this Lakshman Rekha, or if you cross the uterosacral ligament, there is a fair chance that you can go and hit the ureter. So your direction of incision should be such that it can be either oblique, or it can be vertical, or it can be horizontal also. But keep it in mind that you are not going to go beyond the uterosacral ligament. So here you can see that with a gentle traction, you are able to bring the fibroid out. So slowly the fibroid is now coming out, and then you are just advancing the myoma screw. Here, generally in myomectomy, the trick is only traction and counter tractions, and how we are going to walk on the fibroid with the help of the myoma screw. So as and when we are advancing on the fibroid, we have to keep relocating the myoma screw lower down, so that you will have a better traction. So if you give traction from here, now when you want the lower port to come, it will not come. So you have to stop it and then advance the myoma screw little lower down. So you have to stop that and stabilize it, and then if you advance it, then the fibroid will be able to come out easily. So you keep advancing, and then you can see that the fibroid comes out. So I'll forward it a little bit. Sorry. So okay, so you can see that the fibroid has come out almost completely from the posterior surface of the uterus, that is from the cervix. And this is the last bit which is there, and then once it is done, so here you can see that here the entire fibroid has come out, and then once it is done, so here sometimes there will be small little oozes on the bed of the myoma. So I place Surgicel, you can place it on the bed of the fibroids, which is a hemostat. So here these Surgicels you don't have to remove because they are all absorbable, and they are not interseed, mind you, they are Surgicel which are hemostat. So you leave them there, and you can suture the myometrium over it. So in that way, you for sure that the hemostasis, the small bleeders, all will be well taken care. You don't have to even cauterize them, but only thing is you have to suture it properly at the end. So you keep suturing it, and then thereby you can maintain you can give a good scar like this. So finally you pick it, and then you have to morcellate it. So again, this is an in-bag morcellation. I have put the fibroid inside the bag, and then I'm bringing the bag outside, and then I'm going to morcellate it. So I generally do in-bag morcellation for most of my cases. This is yet another very interesting fibroid, the cervical fibroid. So she's been on conservative line of management during the uliprestal days. Now that it is banned, people no longer do. So the basic disadvantage with these medical managements is that they make your plane get lost when you are planning a myome. So here in such a scenario, I'm planning to do a identifying the ureters, and here skeletonizing the uterine artery and keeping. So just because of the location of the fibroids, there is a fair chance of bleeding. So I am kind of inoculating this fibroid, but because of all these medical management, so if you see, the fibroid is so degenerated. So as I'm removing, I'm not getting the plane. When it is like in situ morcellation, it is coming in bits and pieces only. So I had to put a bag inside and then collect all the tissues, and then only remove it, and have kept this open because there was no necessity for, to cauterize it. I have not done the uterine artery ligations. I will show another picture. So principles for a successful outcome in laparoscopic myomectomy is that we need to preserve the extracellular matrix. As a result, as I said, it has to be a totally intracapsular myomectomy, because as this ensures a three-dimensional configurations of the myometrium, and also suturing in 2 to 3 layers is sufficient, as multiple layers can cause foreign body reactions and necrosis. So now coming to the risk of uterine rupture, at present we do not have any consensus that there is an increased risk of uterine rupture after laparoscopic myomectomy, and that the uterine rupture has been removed even after abdominal myomectomy. So the major concern for laparoscopic myomectomy and the subsequent rupture during labor, however, the risk is about 0.6 to 10%, and the risk following myomectomy via any approach, be it the abdominal or the laparoscopy or whatever, it is only 0.93%. So, but you can increase the incidence of rupture if you do extensive coagulation, if there's so much of myometrial damage, if there is defective suturing, if there is poor approximation. So finally, as I mentioned, prevention is the most important factor that we need to keep in mind, especially in case of infertile patient. So the prevention strategies are that you should have a good surgery with respect to minimal destructions and handling of the tissues, avoid unnecessary organ manipulations, controlling bleeding, minimal coagulation, and reasonable operating time. And of course, addition barriers using Intercede and other agents. So the post-myomectomy pregnancy rate, it has been found that the pregnancy rate post-myomectomy is about 49%. And people have also reported an incidence of about increase in the pregnancy rate by 57% also. And it is the same whether it is going to be a laparoscopic myomectomy or an abdominal myomectomy. So now coming to the maintaining of hemostasis, a few little other methods by which we can maintain hemostasis is one of them is by uterine artery ligation at origin, which is quite controversial in case of fertility patients, because in fertility patients, we do not want to ligate the uterine artery and leave it there because it is going to hamper the ovarian reserve. So as a result, in women who are very keen to have babies, we do not offer this uterine artery ligation at origin. And if we have to do in certain scenario, it has to be a temporary uterine artery ligation, which I will be showing in the succeeding videos. But here I'm doing a permanent uterine artery ligations where a clip is being identified after opening the lateral pelvic wall, identifying the uterine arteries, which is the first takeoff point of the internal iliac artery. And so you have to see the peristalsis and the pulsations and identify what the structure is and then proceed. So this case, I will be showing the temporary uterine artery ligations where you have multiple fibroids. So here you have to, here you can see that the lateral peritoneum pelvic wall is opened. So as we are opening the lateral pelvic wall, the first structure you can see is the ureter. So the next structure lateral to the ureter is the internal iliac artery, and the horizontal structure which is coming off from the uterine artery, this is a horizontal structure which is the uterine artery. So here our idea is that we need to occlude this uterine artery so that we are able to do the procedure, and finally at the end of the procedure release the suture so that the blood flow resumes and you are able to get the uterus back to its give the uterus back its blood flow. So here you can see that I'm introducing a vicryl below the uterine artery. So after ensuring that the entire uterine artery is skeletonized, so you have to go below the uterine artery also and remove those fibers, and then you have to take a small piece of vicryl, and one end of the vicryl you put a knot, the other end you make a loop, and then you have to throw a knot. So once this is like how you tie the shoe, so the shoelace, no? So that is why it is called the shoelace. And here you put a knot like this and tighten it. So now the blood flow is completely cut off. So you can do the procedure, and after completing the myomectomy, you can release it. So I don't want to show this entire myomectomy procedure. So you can see that at the end of the myomectomy, I'm just unlocking the knot, releasing the knot. That is, you have to pull on the opposite suture, and you can see that the knot comes out. So, and once you release the knot, you can see that the blood start, going, flowing through the uterine artery, and the perfusion of the uterus is well maintained. So finally, all these fibroids are made into a mala and then put into a bag, and then an in-bag modulation is being done again for this patient, and all the, right. So this is a bag, and then the myoma is being dropped and being modulated inside. So this is temporary uterine artery ligation at origin. So it is not a must, but then in certain cases, if necessary, we may have to do it. Again, so these are few of the interesting videos I thought I will share. This is again a huge uterus, like you have a fibroid of about 22 to 24 weeks, like. So this fibroid, if you see, it is a totally cystic fibroid, which is so soft. So generally you have hard fibroids, calcified fibroids. So that's why I said that each and every fibroid is different in each and every woman. So in this case, if you say I have not used a myoma screw at all, I'm trying to gently inoculate with just, with a non-tooth or tooth grasper, and trying to just, separate the fibroids. So these fibroids only, we always have a very constant fear in our mind as we are operating, because there is a very chance, a fair chance of being a leiomyosarcoma. So we do all the necessary investigations, but still, when you look at the consistency of these fibroids, the nature of the fibroids, it is quite scary. So in such a scenario, it is always better to do an in-bag modulation, because these fibroids, if you see, when you're modulating it, the tissues will keep going all over the abdomen. There'll be so much of fraying of the tissues that the tissues get scattered all over the abdomen. So as a result, if you put them inside the bag, it is all contained inside the bag. So as a result, you won't cause any kind of parasitic fibroids in the postoperative period. So see how much of tissues are left inside the bag, the fluid. So that's all the fluid which has been coming from the fibroid. So all these things can be removed in toto when you do an in-bag modulation. So major advantage of in-bag modulation. So you can see that the entire, this is the amount of fibroid tissues which we have removed by in-bag modulation. So I have to show you a technique of in-bag modulation, which I'll do so. And then this is again another kind of, this was pre-operatively, it was thought to be a fibroid uterus. Okay. So even with the assumption that I'm going to do a myomectomy, I started this procedure, but then it turned out to be an acute, or whether it was it is a so non-communicating uterine horn was constantly there in the mind. So here the patient had undergone cesarean section, and she had come with a huge mass, so which looked totally like a fibroid. So this is a mass, and this is a uterus. But then if you see, this doesn't look like a non-communicating. It looked, more in favor of maybe a non-communicating horn, but then there are no other features suggestive of it. So I thought it is going to be a fibroid and started the procedure. So but then after all these were additions because of the previous surgery she had, that is cesarean section, and after releasing it, you can see that the entire lower segment was occupied by this mass. So pitocin was injected. So let me forward it. The pitocin was injected, and the fibroid mass is being enucleated. So as I'm enucleating the fibroid mass, you can see that it is not having a proper capsule, and so with the assumption that it is not a fibroid, and or maybe it could be a cystic adenoma, just proceeded and then found to be an acute accessory cavitated uterine horn. So it had a cavity with all the adenomyotic tissue. So that was a cavity there, and then this is the mass. So the entire mass was removed, and after that, so that you can see the cavity with the elevator, and the wound is now being sutured. So finally, the entire tissue is then put inside the bag, and see, can you see that it is an adenomyotic? So the chocolate material is coming from the fluid, from the mass. So this is also all suggestive of acute. So if it is a fibroid, you will not have this chocolate material. So it is more in favor of an acute rather than that of a fibroid. So this is also a reason why we need to do an in-bag modulation, because these adenomyotic, that is tissues, something like endometriosis, if done on open modulation, then it can go all over the abdomen. So now let's focus on in-bag morcellation. Of course, FDA has put in a warning after the incident that took place to Amy Reid not to, do an open morcellation because of the fear of leiomyosarcoma dissemination. So the picture in the lady is Dr. Amy Reid, after which there was quite a lot of commotion. In fact, was an anesthesiologist and she had undergone a total laparoscopic hysterectomy for a huge fibroid. But then, she's such a she's got such a beautiful family with six lovely children. So, but what happened was after the TLH procedure, the postoperatively the report came as leiomyosarcoma. So her husband, a cardiothoracic surgeon, he knew the intensity of the situation. He knew because of morcellation, the disease would have got upstaged. And as a result, he ran a campaign, and then the FDA had to put a warning and a caution notice. Also, a black box warning also came in, and morcellator became the eye of the word storm, and most of the morcellators went out of the market, but for the stores. So this led to how the change in the practice and however, but the irony of the situation is that if it is a leiomyosarcoma, if not necessary that if you do an abdominal myomectomy, you're going to prevent the dissemination or reduce the incidence of dissemination. If it is going to be even an abdominal myomectomy, the scenario is going to be same, because if you any kind of breach in the tissue can upstage the disease. So as a result, there were quite a lot of talk on this, and so people started thinking more deeper. So ultimately, human mind is really phenomenal. So innovation is seeing what everybody has seen and thinking what nobody has thought, and this led to the invention of the in-bag. So they said that to some extent, at least we can prevent the dissemination of these, malignant cells if you put the mass inside the bag and morcellate them inside the bag rather than doing an open morcellation. So with this came up the many bags, the innocence bag, the surgical gloves also people started using, but then the Marseille bag, the Lima's bag, all these have stood the test of time and it is being utilized now. So which are nothing but a polyurethane bag which comes in various sizes, and you can get the mouth of the bag is almost 13, 15 and 17. So even huge fibroids up to 20, 24 size fibroids can be done with in-bag morcellation. So this I will show you how exactly I do this in-bag morcellation. So this is yet another case where I'm doing a myomectomy. So here after the fibroids are being removed, I'm sutured it, and then hemostasis well secured. I'm parting. Okay. So I'm parking the fibroids there, and now see I'm introducing the bag inside the peritoneal cavity. So once the bag, see the technique is how you introduce the bag inside the peritoneal cavity. Many a times, if you don't introduce the bag inside the peritoneal cavity properly, there is a fair chance for the bag to twist. So if the bag gets twisted, then your procedure becomes very cumbersome. You will not be able to do it. You will not be able to create the pneumoperitoneum, and you will not be able to introduce the morcellator. You will not be able to morcellate. So you need to introduce you have to introduce the bag properly, and then finally you catch hold of the tail. So that is the tail of the bag, and then I'm bringing out the tail of the bag through my camera port. So I generally use endo tip. So you can see my endo tip, which is bringing the tail out. So once the tail is brought out, and then the tail has a small little hole through which I introduce the trocar and again create the pneumoperitoneum. So once a pneumoperitoneum is created inside, then through the mouth of the bag, I am introducing the morcellator. So now the morcellator is brought inside the bag, and I'm going to morcellate this fiber. So there is a learning curve for this, because people find it very cumbersome. They try to avoid doing this in-bag morcellation. But then once you learn the technique of this in-bag morcellation, then it becomes very easy. So basically, people think that it takes quite a lot of time to do it, but then you should understand that in the extra 5 minutes that you take to introduce the bag, you can avoid going behind the tissues at the end of the procedure. So in fact, the time gets compensated. So once you are done with the morcellation, so this is how it is. The tail has come out through the camera port, and the mouth of the bag is through the lowermost port. So you have I put a knot so that that pneumoperitoneum is well maintained, so that I'm able to morcellate properly. So this tail and tail of the bag, which has got a small little eye, I am kind of putting a knot there and occluding the knot so that there is no leakage of any of the tissues or the fluid from the bag. So then the bag is brought out by pulling the mouth of the bag, and then finally this is the port through which the mouth of the bag came out, and this is the tissues which have been morcellated. So it's a very simple technique. Only thing is you have to master it. It's small learning curve. So the single port in bags have also come. And these are so definitely one bag came in, and then there are many other competitions. So there was a point when the market was flooded with many, and so this is another kind of in bag morcellation. So here this is called the limas in bag morcellation. So here again, so every bag has its own technique. So this bag, if you see, it comes like this. It's rolled up. Whereas if you see the other bag, the morcellation bag, it will come like in open. It's like a bag. It's like a stomach. But this bag will come in a folded form. So it is quite easy to introduce this bag itself right inside the abdominal cavity. All that you need to do is just put it inside the abdomen in the way it was there, and then withdraw the stillet which was there inside the bag. Then you have to, but only thing is here in this particular bag, we should know how to open the bag. You have to open the bag properly in such a manner that the mouth of the bag is facing anteriorly. So once you open the bag properly, then you have to go right up to the base of the bag, because this bag is nicely folded and kept. Okay, so we have to go right up to the bottom of the bag and open it nicely. So you have to spend some time to get the position of the bag properly and align it in such a manner so that you are able to drop the fibroid inside the bag. So again, this bag also has a tail, and it has a body, and it has a mouth. So now if you see, I am opening the bag now properly inside the abdominal cavity, and then this is the mouth of the bag, and now I'm picking the fibroid and gently dropping it inside the bag. So again, now the techniques are almost going to be the same. So you have to bring now the mouth of the bag outside. So again, you are catching hold of both the lips of the bag and bringing out through the lowermost port. So that is the upper lip of the bag, and this is the lower lip of the bag. So I'm trying to push the fibroid right up to the bottom, so that there is no herniation of the fibroid anywhere inside the bag. So you bring it out, and as you bring the bag out, so you have to ensure that the bag is not twisted. So just keep it outside, and you have to make sure that it is properly occluded. So you're using a clamp to occlude. And then now I'm bringing the tail of the bag. So here, if you see the tail and the body of the bag, there will be a small valve. So that is the difference between the morcef and the limas. So in the morcef, you do not have a valve, but if you see in the limas bag, you have a valve. So it has got its advantage also as well as disadvantage also. So, but the thing is, like when you are introducing a trocar, you have to introduce it in such a manner that you are able to negotiate the valve. I mean, the inside that is the junction between the mouth, the body and the tail. So that you have to identify. Can you see that? You have to identify the valve properly and negotiate your scope inside that. So if you do that properly, you will kind of perforate. So that is a small learning thing curve for every bag, every technology and everything. So finally, I try to check the integrity of the bag by filling it up with water. So I know that there is no leak. So ultimately, poor little Dr. Amy Reed, after struggling so much for almost 3 years, she passed away. She lost the battle, but then she left a very good innovation, that is an in-bag. So peritoneal washings have also been found to have spindle cells, so even before doing modulation. So all the more reason why you have to be very careful. So this is another drawback with open modulation. This is a case of port site myoma. So this particular lady, in fact, to be frank, this particular lady, I had done an myomectomy, and that those were the days when beginning days when we didn't have a modulation or no impact, nothing. So we would literally used to cut these fibroids and bring them. So this is the fibroid which has developed at the port site. So she came back again now recently 2 years back with a mass in the port site. So it was a fibroid which she had developed. So all this can be avoided if you are doing an impact modulation. So this is again yet another case of a huge broad ligament fibroid. So this was almost to 1.5 kg fibroid, and here you can see this huge broad ligament fibroid going right up to the bladder. So right up to the vascular structures, all the vital structures on the lateral pelvic wall. You have the vessels and the posterior. So it occupies the entire thing. So here, though they say the broad ligament fibroids are very easy, but then you should understand that the extension of the broad leg, here you have the ureters, here you have the vascular structures. One need to be very, very careful when you encounter a huge small broad ligament fibroid. It's a child's play. But then when you encounter a huge broad ligament fibroid, you have to be very, very meticulous with your dissection. Here there won't be much suturing because there is not much of the myometrium involved. But then your trick and skill lies in the dissection of this fibroid from the vital structures. So here I have to gently inoculate this fibroid and then remove it. I think we are running late, so I will just forward it a little bit. So you can see that the entire fibroid is now being brought out from the lateral pelvic floor and the lower down. Also, you have to keep on identifying the ureter, the uterine artery, the internal iliac artery. So here the lateral pelvic wall, it is all free, and then it is gently inoculated. So finally, I put this huge one inside the bag and then modulate it inside the bag and bring it out. Okay, so yet another one. Okay, so this I wanted to show because sometimes we can also get burn our skin when we think it is a fibroid and it turns out to be a leiomyosarcoma. So this particular case in fact was thought to be a fibroid and turned out to be a leiomyosarcoma, but luckily I had done an impact modulation for this particular lady. So though all the problems of leiomyosarcoma this lady had to go through, and of course eventually she lost the battle also because the prognosis was bad. But then what we have done is even the she wants to refer to the oncosurgeon. They also said because all the necessary precautions were also done and also the impact modulation was also done, so we can't do anything much because the nature of the disease itself is like that. So that is the reason why we have to do an impact modulation, because many a time we think it to be presumed fibroid and it ends up to be a leiomyosarcoma. So we, at least to save our skin in the court of law, we have to ensure that we are doing a proper work so this is again very interesting. I just wanted to show this is a TLH was done and it turned out to be a leiomyosarcoma. I mean, in fact, she did not have leiomyosarcoma in neither in the uterus or in the pelvis, and the HP came as a fibroid. But if you see, this is a very, very rare case of leiomyosarcoma. I just wanted to show it because it is a fibroid case. She developed a leiomyosarcoma of the abdominal wall. That is, leiomyosarcoma can develop from anywhere, right? Because it's a smooth muscle tumor. Her pelvis, her entire abdomen was totally clean even after 6 months. But an abdominal wall had after 6 months. So she had developed a leiomyosarcoma from the smooth muscle of one of the vessels of the anterior abdominal wall. So initially I thought it was an abscess, and then after thorough evaluation, looking at everything, so caught all the gastroenterologists, everything, MRI done, everything, pelvis was clean, abdominal cavity was clean. It was found to be a mass on the abdominal wall, thought to be an abscess, but unfortunately, the report came as leiomyosarcoma. So these are the two, in fact, rare cases of leiomyosarcoma which I have encountered. So though the incidence is rare, but then we have to keep in mind. So this is yet another very interesting case where you can see that the fibroid can also arise from the extrauterine sites. So here, this particular lady had no fibroid surgery or anything. She came to me for a myomectomy for an anterior wall fibroid. I was also in the impression I'm going to do an anterior myomectomy. But then on introducing the scope, this is what I see. I see the fibroid which was arising from the lateral pelvic wall, which is completely detached from that of the uterus. So you can see that I'm not even able to put the secondary trocar. It is hitting on the fibroid. So that is the origin of the fibroid. It is coming from the lateral pelvic wall. So I avoided putting the secondary trocar. I just put only one trocar, decided to enucleate a little bit, create some space and introduce the other trocar. So you can see the groove now. So here, can you see that this is a fibroid and this is a uterus? Can you see the groove? Can you see the groove between the uterus and the fibroid? So there is absolutely no connection between the fibroid. So it has developed purely from the lateral pelvic wall. So this can see there are various theory for the development of the fibroids from the lateral pelvic wall. So probably a broad ligament fibroid with the pedicle getting cut from detached completely from the uterus and developing parasitic blood supply from the lateral wall, or it could be even most of these cases we have to be very careful that it could be a tumor also. So metastasis or static tumors or something hormonal sensitive smooth muscle elements, all embryonal remnants from the Mullerian nest arising from the lateral pelvic wall. So all these things are, so luckily for this lady, she did come as a leiomyoma. And she also had other so I had to gently forwarding it a bit. So again, all the vital structures in the lateral wall have to be taken care, and then the fibroid was enucleated. She also had small little other fibroids which were also removed at the same sitting. So this is a very interesting case which I encountered, that is an intravascular leiomyoma. So this particular lady, though it was a hysterectomy, I want to show here because there is a variant called the intravascular leiom. Can you see the tissue which is coming out? She has a very, very vascular, fibroid. So TLH was little bloody. So as I am detaching the uterus from the uterine artery, this small little tissue which is coming out. So she had a huge fibroid in the inside the uterus. It was a submucosal and intramural. And this was a tissue which was coming out. In fact, I was not sure what exactly the tissue is going to be. So retrospectively, it was the diagnosis. So the tissue which I pulled out from the one of the vascular structure, I just kept it separately for biopsy. And then you can see that bit small, another bit which was also coming out. Then this was found to be an intravascular fibroid. So just cauterizing a bit, it's a very bloody field because the fibroid is very vascular in spite of TLH. There was quite a lot of wounds. So then there is, you can see one more, just keep a note on this structure. So this is again another band which is visible there. So I don't want to disturb it, so I just left it aside and wanted to finish the procedure and look into the structure what it is. So we have a pulsating uterine artery which is here. And close to that, there is another band which is sitting there, not knowing what it is. So I just wanted to finish the procedure. But after finishing the procedure and as I removed the fibroid out, because of the traction, there was quite a lot of bleeding from the wall. So, and also this structure which was there as a small one, you can see that it has now enlarged and it has become big. So, and there's quite a lot of oozing. So I had to first decided I will only first secure the hemostasis and tackle the structure, which is now becoming longer. It is getting elongated now. So the hemostasis is being taken care, and that is being addressed first before removing this band-like structure which is there. So once the hemostasis is secured, then creating the plane properly and identification of the ureter, because this structure also looked like an ureter, so it gave me lots of fear in my mind whether did I ever damage the ureter. So definitely, obviously, when you kind of when you are in a situation like that, you tend to think the worst possibility. So you look for the ureter, so see the peristalsis. So well away, the ureter is well away from the this band-like structure. So here you have the ureter, which with its beautiful peristalsis, and here you have this band-like structures, which is just coming out from uh, one of the structures from the lateral wall, maybe from a artery or a vein, not sure, but it cannot be from an artery because uterine artery was pulsating when that was cauterized. So must be the structure is coming from the vein. So can you see the peristalsis? So we are well away from the ureter. So this structure now, which is coming from the vein. Okay, so it is just popping out from the vein, has to be now removed. So I'm just trying to decide like how I'm going to remove this structure. So because it should not bleed profusely also. So I'm just gently giving a traction on the structures and trying to remove this structure. So once I remove that, you can see the bout of bleeding. So so first decided to remove it and then arrest the bleeder. So I'm removing the structure and said I don't want to make it into piecemeal, so just parking it inside the wall so that we can remove it like that. So this is the bleeder which is happening. So the next most important thing is I'm going to catch hold of the bleeder with my non-tooth grasper. So I have to make first up, arrest the bleeder, then I will take care of the hemostasis, and then I will cauterize. So I'm using my non-tooth grasper to hold on to the bleeder, so I know I'm holding the right structure, and that is the point of bleeder. So when you encounter any bleeding, this is a technique, in fact, not only in this case, any case for that matter. When you encounter bleeder, always identify the bleeder and then catch hold of it. So once you identify the bleeder and catch hold, you can make the vision properly, but you'll get a proper field, and then you can cauterize. So then once I identify the correct site and held the bleeder, then I'm cauterizing it with a bipolar, ensuring that the bladder has been pushed off and then there are no other structures coming in. So with this, always try to go slightly away from the lumen so that you will have a better hemostasis. So once this is done, again a thorough suction is being done, and then you can see that the vascular structure, so this particular lady also had a huge cyst in the ovary. So the TLH was done and the oophorectomy was done. The ovary was parked outside, I mean separately. The urobag was introduced inside the abdomen through the vagina itself, and I wanted to, she was a postmenopausal lady, so I wanted to ensure that it is brought out without any spillage. So I'm bringing this entire mass through this urobag. So you can see that through the vagina, I'm trying to aspirate the fluid and send it for cytology also. Not sure, though it did look clear, and it of course benign, but still we have to take all the necessary precautions when we are doing in a postmenopausal women. So this is the end of the story for this particular lady, and of course again having a look at the pelvis, and we are ensuring that the hemostasis is well secure, there are no bleeders. So the the biopsy came as a smooth muscle mass, that structure. So this is yet another case, that is this particular lady again. She had recurrent endometrioma and submucosal fibroid. So again, so this there are two fibroids there. We can easily remove it with hysteroscopy, but then so I decided to remove this fibroid laparoscopically itself, because anyway I had to do a laparoscopic procedure for this particular lady because she had endometriosis and endometrioma. So I'm just trying to assess how many fibroids are there inside the cavity. And so though it looked small, but then when she came with the report, it was something like a 5 centimeter fibroid submucosal. Sorry. So I had to remove this fibroid, and then finally, I think something wrong with this video. Okay, so I think with this, we come to the end of the presentation. So I have shown you different kinds of fibroids and different varieties of fibroids and myomectomy in different scenarios, and also the technique of in-back morcellation. So ultimately, laparoscopic myomectomy is a very rewarding procedure done in patients with very clear indications and following the right techniques. So thank you so much for your patient listening. And I will also like to thank Shield Pharma for this excellent academic activities which they are doing. Thank you. I'm open for questions.
Thank you, madam, for such nice talk, and especially with the pictorial and videographic demonstration. It made the presentation very nice. So thank you once again. And meanwhile, I received few questions, and if you permit me, then we can have a small discussion on that.
Yes, please go ahead. Yeah.
So, ma'am, first question, it appears, what precautions for the second pregnancy if the woman has already undergone the myomectomy surgery previously?
Yeah. See, basically, the most important thing one needs to understand is that when you have to plan your pregnancy, so after a myomectomy procedure, we should at least give a minimum time frame of about 6 months for the wound to heal, uterine wound to heal. So, or you have to ensure that, the vascularity in the wound is well established. So how can you establish whether the vascularity has been well established inside the myometry, for which you can do an MRI or a Doppler, color Doppler, and you can see whether the blood flow in the suture site has resumed. If the blood flow in the suture site has resumed, that means the scar has healed well. So this particular woman is now ready to go through a pregnancy. So that is the most important thing that one needs to keep in mind.
Okay. And the second one is, what is the recurrence chances of this fibroid? Means, is there any recurrence chance?
Yeah, but then the fibroid, we all know, no, the genetic nature of the fibroid is such that it can have a tendency to come back all over again. So, so that is the reason, we cannot give any women 100% guarantee that, she will not get any fibroids. The constant question every woman asks is that, doctor, after this fibroid removal, will I be getting any more fibroids? So that we don't have any answer. We never know the genetic nature of that particular woman. If she has a tendency to develop the fibroid, she can develop a fibroid. But one thing I generally tell my patients is that I will definitely remove all the fibroids that I can, see. But if you are going to develop some seedling fibroids in future, then I have absolutely no clue whether you'll be developing fibroids in future or not. But then even if they develop fibroids also, they are going to, develop after quite some time only. So at least the fibroids which are now and disturbing her can be removed so that she can have a better quality of life. That's how you need to look into it.
Okay. Okay. And madam, in our platform one, Dr. Aruna Kumari asked, what is the trade name of injection vasopressin?
Vasopressin is pitressin. 10 units in 100 ml is the dilution that you give.
And madam, I have one question. If excessive blood loss or myometrial hematoma was there, so what immediate strategy you used to take in the surgery table, or is there any life-threatening condition if excessive blood?
See, that's
what is the risk associated with that?
Yeah, the most important thing is the bleeding is the main important concern in case of a myomectomy. So that is why you have to take all the necessary precautions to make sure that your blood loss is very, very minimal. So for which only we are doing this uterine artery ligation at origin, injecting vasopressin, and ensuring that you are in the right plane. That's very important. If you are in the right plane, there won't be any much blood loss. Only the very fact that you're having a bloody field itself shows that you are not on the right plane. Okay, so but once you encounter that you have quite a lot of blood loss, then you should know how to arrest that also. So you have to identify where exactly it is bleeding, by which site it is bleeding, and you have to gently go and cauterize it. just cauterize it a little bit and secure hemostasis a little bit, and then you can start suturing them. So that is why you have to be very proficient in your suturing skills when you do a myomectomy, because many a times, you cannot just rely only on your energy source. Energy source, the spurts you can cauterize, but then ultimately, if you are very good in suturing, your good suturing itself will be able to take care of their bleeders.
Okay, madam. So I have my last question, madam, that can women do some physical activities after myomectomy performed? Means at up to what time it is restricted, some physical activities or
Okay.
other things in normal life means?
Okay, fine. See, basically, like laparoscopic myomectomy is a minimally invasive surgery. She has all the benefits of the minimally invasive surgeries. No, like her recuperation is very, very quick. She's able to get back to her all activities in a week's time. She can do all her regular household work, like she can climb stairs, do everything. All the only thing is like she should not do anything very, very strenuous as such, but then otherwise the recuperation is very quick. She can lead a very normal life. In fact, most of my patients, if you see, within 2-3 days they will not know they are operated also, because they'll absolutely be free from pain. They're hardly there in the hospital for a day or so. So once they go home, they walk and go comfortably and carry on with their routine work. So that is the level of recovery with these laparoscopic procedure, be it a myomectomy or any other kind of a procedure with laparoscopy.
Okay, madam. So I could not find any question again. So if you permit, then we can conclude here. And thank you very much, madam, for your valuable time. And next means we are looking forward in near future for some. We will get back to you for some knowledge.
Yeah. Thank you so much.
Thank you, ma'am.
Thank you.
Thank you.
Thank you.
Thank you, ma'am. Prachi here.
Yeah. Thank you,
Thank you
Dr.
very much.
Prachi. Yeah. See you all. Bye.
Yes, ma'am. Bye-bye.
Bye.